You think of menopause symptoms, what comes to mind? Brain fog, mood swings, panic attacks, anxiety that you just can't seem to shake. Today I'm sitting down with Dr. Fionnuala Barton, aka the Menopause Medic, a UK-based GP and women's health expert who specialises in menopause. In this episode, we're discussing everything from HRT to stress, perimenopause, and what exactly is happening to our bodies during this time. Finn has dedicated her career to empowering women to take control of their health and wellness. She's built the Menopause Medic, an online platform with comprehensive menopause advice, online coaching, and digital resources to help women navigate their menopause journey. With her unique blend of clinical and personal experience, she offers a holistic and personalised approach to navigating menopause that you won't find anywhere else. So if you're looking for answers and support from a medical specialist who's also caring and compassionate, you don't want to miss this episode. Hi, Finn. Welcome to Unpause the Menopause. We're absolutely delighted to have you with us today.
Thank you so much for having me, Morven. And it's so lovely to hear an introduction like that. You go through life thinking, one thing about yourself. It's really nice to hear how other people might describe me. That was lovely. Thank you.
Well, you're doing wonderfully well in the menopause sector, so we're so delighted to have you on with so much expertise. We tend to start the show with a bit of a stranger question, but I find it one of the most interesting ones. How do you start your day? What do you do to set yourself off for a productive day?
So I'm going to rewind a little bit with that and say that this is something that I have adjusted considerably in the last couple of years as I've been going through my own sort of perimenopausal hormonal journey. And now I really prioritise having sufficient time in the morning to do what is necessary. So, drinking a glass of water, having a cup of tea or coffee, spending time with my children, and getting outside into daylight as early as possible every day. So going for a walk, or at the moment, as I mentioned earlier, marathon training. So getting out for a run some days of the week in fresh air in order to get that daily sort of early morning light exposure that I find really useful. And being outside, I find it really good for my mental health. I find it energizing, and it's just a really good way for me to start the day. When I worked as a GP or as a hospital doctor, that just wasn't available. So, you have to be on your chair in clinic at 8 a.m. or 9 a.m. sometimes. And as a result, just didn't get the opportunity to do that. And so it's a really important part of my new lifestyle, I suppose.
And I think it gets more important as we age as well, to get outside and just have that time to yourself and feel like you're prioritizing yourself as well in some way.
Absolutely, yeah.
Now, it's clear that you've been focusing on women's health for your whole career, pretty much. But what inspired you to do that, and what inspired you to focus on menopause particularly?
So I think it's a combination of professional experiences and personal ones. I remember just being really interested in women's health issues throughout university in my early years after qualifying for medical school. But I was also very interested in, lots of other things, and which is why I chose general practice as a sort of career choice, really, rather than obstetrics and gynecology. Also because I've got terribly low blood pressure, and I found that I kept passing out in operating theatres, so figured a surgical career wasn't necessarily best suited for me. And I think actually inadvertently along the way, I realised what my strengths were and what my weaknesses were, and what I enjoyed and what I didn't enjoy. And over the last, 5 to 10 years have sort of, I suppose, aligned what I've chosen to do with some of my core values. And I've always been more interested in the women's health aspect of things. My mother had a very difficult menopause journey, and I started experiencing perimenopause myself in my late 30s, which was obviously far younger than we expect that to happen. Didn't realise it at the time, of course. The value of hindsight is always really useful. But when I was practicing in general practice and seeing women's health issues, it was something that I found I really enjoyed, and it was something that I found I was pretty good at. And the more I read, the more I researched, the more qualified I became, the more able I was to provide an expert service to the women that were coming to seek my advice. And that in itself was enormously valuable and rewarding for me. So it all kind of just gained momentum from there, really.
And you decided then to switch from GP to actually running the Menopause Medic and the Menopause Clinic.
Yeah, so I still do a little bit of NHS GP work, but that's sort of something that I probably won't be doing, forever. I shouldn't imagine, and do a little bit of NHS menopause work as well. But my predominant work is running the Menopause Medic platform and the clinical services that we offer. And yeah, I thoroughly enjoy it. And actually, being my own boss means that I am in control of my hours and that I am able to do things like prioritize what my needs are, start the day as I feel it needs to be started. And at the moment, also sort of ensure that I'm there for my kids who I've still got with me. At the moment, they haven't quite left the nest yet. And that's a real important factor for me. I realised when I was, in my early postnatal years, going back to the grindstone and working incredibly hard, I missed out on several years of my young children's lives, and I didn't want that to be the case, before they left home. I wanted to have a few more good years with them before that happened.
I love it. So you're actually practicing what you preach, which is great.
Absolutely, absolutely.
If we delve right into one of the main menopause symptoms, and I know it's something you've talked a lot about, it's brain fog. Now, I had a corporate city job, and it was important I could talk to people and chat around, and I found that I couldn't finish sentences. The words just escaped me completely. That was my way of doing it, my way of having brain fog. And I know some people forget names and places. Why is it such a common symptom, and what is medically happening in our bodies that occurs?
We all, I think, visualize menopause and perimenopause as being an ovarian issue, but so many of the symptoms we experience in perimenopause and menopause are actually primarily problems in the brain. And that's because estrogen is a really potent, positive neurotransmitter, effectively. It has lots of positive effects on many different parts of brain function. Areas of the brain that are involved in memory, in decision making, in word finding, in complex sort of decision making, forward planning, but also things like perception of fear, and as a result, things like risk taking or feeling confident in certain situations. And so when the ovarian estrogen levels change, the cells in our brain that have been relying on that estrogen through our premenopausal years aren't getting as much of that substrate, that estrogen, to do the job that those cells have been used to doing and working in a way that they've been used to working. So nerves can become, less effective or efficient at doing what they have been used to doing, and it's a shift change. Also, the ovaries stop producing testosterone in sufficient quantity from about our 30s throughout our 40s, and then don't produce any testosterone from the point of menopause either. We can produce a bit of testosterone in the adrenal glands, but testosterone also has a really potent effect on similar areas of the brain. And so when we've got lower levels of estrogen and testosterone, it can have a sort of double whammy effect on the function of those important cells in those important areas of the brain. But actually, if you do then sort of look a little bit deeper, women will experience very different symptoms in terms of cognitive dysfunction. And of course, they will have then a different impact in terms of their function. So for example, for you, not being able to find your words or articulate yourself clearly in the context of your role in your job had a substantial functional impact. That might not have the same substantial functional impact, and it might then not drive quite so much anxiety for somebody who isn't being expected to stand up in the boardroom. We also have, as a primary function of low estrogen, difficulty sleeping. We can experience difficulties getting to sleep, difficulty staying asleep, and difficulty accessing the deep REM sleep that our brains need in order to process a lot of the information that we've experienced during the day. So if we're not sleeping and we're not accessing deep REM sleep, we're waking unrefreshed, and actually we're starting from a kind of back foot in terms of cognitive function. And then you add all of the other stuff going on, the stress, the worry, the anxiety, the busy life into that already hormonally slightly deprived system, and it's a perfect storm, and it can be enormously devastating.
So many things that you've just mentioned there that I want to touch on. So let's go first on to HRT though, because I think that's probably what a lot of our listeners will want to talk about. And what HRT involves if somebody's not already taking it, and what you see are the benefits and potential risks of taking it.
I'm a really proactive prescriber of hormone replacement therapy, but I didn't used to be. Generations of medics that have gone through their medical education and subsequent postgraduate training thinking and believing that hormone therapy was very, very dangerous. And it's only really been in the last 10 to 15 years that we have seen research emerge that countered that message and that said, no, HRT doesn't cause cardiovascular disease. It actually helps to prevent and to improve cardiovascular health outcomes. And likewise, the risk associated with using HRT and breast cancer has been substantially overemphasized. Most up-to-date research suggests that actually for women using estrogen only hormone therapy because they don't have a womb, because they've had a hysterectomy, there isn't any statistical increased risk of breast cancer associated with estrogen only HRT. And I think that that's a really important point to make, because I think we think about breast cancer as being estrogen related. And of course, we have estrogen receptor positive breast cancer. So it's a logical sort of connection to make. But what we see is that with combination HRT, which is what the vast majority of women will require, that's when we see a small statistical increased risk associated with HRT use. And I've chosen my words very carefully there because it's an association and we don't know that it's a causation. And in terms of quantifying that risk, so approximately between the ages of 50 and 59, there'll be between 16 to 20 cases of breast cancer per 1,000 women per year at baseline in the population. We're all at risk of breast cancer by virtue of having breasts and aging. If you add combination HRT to that, that number increases by about 4 cases per 1,000 women per year. It's a relatively small increase. To contextualize that, if you drink alcohol within 14 units of alcohol a week, which is what is recommended as the maximum we should consume a week, that increases breast cancer risk by 5 cases per 1,000 per women per year. So it's actually a higher risk to be having a few glasses of wine with your dinner a few times a week than it is to be on your hormone therapy. Likewise, actually, an even bigger breast cancer risk is being metabolically, inactive or unwell. And the advice is now very clear that women using HRT should use it for as long as the benefits outweigh the risks, which is, again, a really individualized thing based on how much benefit women will see from their HRT. The benefits aren't just the symptom relief and the improved function, but also silent benefits that you might never feel. And they are improvements in cardiovascular health. So we know that estrogen is protective to the cardiovascular system. It helps to keep blood pressure low, and it helps to keep your cholesterol levels nice and healthy. It improves or promotes HDL, healthy cholesterol molecules circulating in the bloodstream, and helps to keep that in balance with the LDL, or the sort of saturated inflammatory cholesterols that can fur up the arteries. And those combination of changes means that women on HRT tend to have lower risks of angina, heart attacks, blood pressure problems, strokes, or peripheral vascular disease or vascular dementia. Now, when you consider that cardiovascular disease and vascular dementias are two of the biggest causes of death in women in our 80s, to be taking medication in a preventative way in our 40s, 50s, 60s and 70s is actually a really positive thing, provided it's safe. The other benefit that we know about but we don't necessarily feel is the benefits on bone health. We know that when estrogen declines, it has an impact on our bone density. And without estrogen, bone density can start to drift downwards quite dramatically from our mid-40s onwards, really. And that can put us at increased risk of having osteopenia or osteoporosis later on in life. In terms of what HRT is, it's replacement of the hormones that aren't sufficiently produced naturally, either in perimenopause or menopause. And perimenopause we describe as the period of time leading up to the point of menopause. Menopause is the point at which you haven't had a natural period for 12 months. And the primary element of hormone therapy is estrogen, because that's going to be the element that's going to provide symptom relief and all those protective benefits. But for women who have not had a hysterectomy, i.e. they still have their womb present, we need to prescribe progesterone alongside that estrogen. And the reason for that is when you give estrogen alone, what happens is very naturally and normally, as does happen during the normal menstrual cycle, The influence of estrogen means that the womb lining gets thicker over time. During the menstrual cycle, this then prepares the womb for a fertilized egg should one pop along. But obviously in perimenopause and menopause, if you've got that womb lining thickening and there is no ovulation happening, then that thickening can start to transform and become either hyperplastic or sometimes precancerous or even cancerous. And that's why we need to prescribe the progesterone alongside the estrogen in order to make sure that that womb lining doesn't get too thick and doesn't transform into something sinister. And it's a really important point, especially recently. There's been lots of supply issues with HRT. A lot of people haven't been able to get hold of adequate progesterone, and it isn't necessarily the nicest element of HRT because you don't always feel better with the progesterone. But it's a really important element in order to safeguard women against the risk of getting endometrial cancer as a result of being on estrogen alone. As I said, if you've had a hysterectomy, there is no endometrium, so you don't need to be on progesterone unless you've had what we call a subtotal hysterectomy. So for certain medical conditions, then they might leave part of the cervix, or for example, in endometriosis, where there might be endometriotic deposits in the pelvis or on the bladder or the bowel that haven't been removed entirely at the time of hysterectomy. It's important that those women are considered to use progesterone as well, just in case any remaining sort of deposits of endometrium have that capacity to change over time. So I hope that makes some sense.
That made so much sense and such a full answer. And I think it's so important to understand all the sort of different layers of the benefits of having HRT, because it's not just, like you said, the immediate response or maybe feeling better. It's about long-term wellness and longevity. And that's what it's giving us. And that's what we want. We want to live well for as long as possible, not just live. And you talked about, there's a few points I want to pick up on there. You talk about combining the HRT being estrogen and progesterone. Is for the progesterone, you don't take it all the way through your cycle, do you?
So it depends. And I think this is a really important question to answer actually in its own right. So before the point of menopause, when women are perimenopausal, if you give estrogen and progesterone continuously and you've got your own natural hormone cycle still going on in the background, the HRT isn't strong enough to completely suppress your natural cycle in the same way that using things like the contraceptive pill did or do. So you have the hormone therapy, but you still have your natural hormone cycle going on in the background. And if you give women who are still having periods continuous combined HRT, they'll continue to bleed, but it might be erratic or unscheduled or unpredictable. So in the perimenopausal women, what we tend to do is prescribe estrogen continuously through the month with progesterone for a phase of the month. And that would normally be either 12 to 14 days of the month towards the end of the month, to coincide with where you naturally would have had your luteal phase of your cycle, so the second phase of your cycle, when your natural progesterones are going to be higher anyway. And if we can superimpose that sequential or cyclical regime of HRT on top of your menstrual cycle, then what it does is it regulates your bleeding, so you continue to have a bleed roughly every 28 days. But what it also means is, because there's extra progesterone there stopping the womb lining getting too thick, it can mean that bleeds are shorter, lighter, and less painful, which is really important for perimenopausal women, because so often the hormonal changes that they're experiencing means that they can get heavier, more painful, more prolonged bleeds that can be really, really troublesome. So using the sequential regime can be really useful for perimenopausal women. We then use continuous combined HRT in postmenopausal women. So if you haven't had a period for 12 months naturally, then you can use continuous combined. And that's where we use estrogen and progesterone absolutely every day, so that you've got the two in combination. The progesterone is constantly inhibiting that endometrial thickness from occurring, and so you don't develop any abnormal bleeding. There are some perimenopausal women who I would start on a continuous combined regime, and they are women who struggle with problems like migraines. So migraine sufferers, a lot of the symptomology will get worse in perimenopause, because menstrual migraine particularly tends to be worse when there are big shifts from low progesterone to high progesterone, or high progesterone to low progesterone, or big shifts in estrogen. And so a lot of migraineurs will say, my migraines have got so much worse, my periods are becoming irregular. And for those women, actually using continuous combined HRT can be really useful to help even out the big swings. They might still have some fluctuations in their natural hormones, but if you've improved the baseline of both the hormones underneath the surface, it can mean that there's fewer fluctuations, they can get better control of their perimenopausal symptoms and fewer of their migraine symptoms, which are often, enormously debilitating in their own right. And yes, so that's a kind of slight exception to the rule in terms of the perimenopausal have cyclical, postmenopausal have continuous.
That's an important distinction if anybody's heading to their GP and looking for what they're asking for. Now, we've talked about two hormones so far. We've talked about estrogen and progesterone. There's also testosterone going around in our bodies. And when would that be prescribed for women?
At the time of recording this episode, there's lots of controversial sort of interest in testosterone therapy for women. So currently, the advice from the British Menopause Society and NICE is that for women who are optimized on estrogen and progesterone, if they still have symptoms of a low libido despite being optimized on estrogen and progesterone, then it would be sensible to consider testosterone therapy for that group of women, because the evidence that we've got, the high-powered, high-quality research evidence that we've got currently available, only really supports the use of testosterone for the treatment of ongoing libido loss. But that doesn't mean to say it doesn't help in other areas. And this is where some of the controversy arises, because the scientists, the research and evidence-based practitioner in me wants to stick to those guidelines and say, actually, we should be only prescribing it for women who've got low libido, because that's where the statistically significant benefit is seen. But actually, we don't have a huge amount of research. We don't have a huge number of trials to look at in terms of finding the evidence we need to support the use of testosterone for other reasons. And anecdotally and observationally, we've been using testosterone to treat women for decades. And I think, I speak for myself, but in conversation with so many of my clinical colleagues, we see benefits with testosterone therapy that go far beyond the libido or reproductive function. We see improved cognitive function, we see improved mood, we see improved energy availability, improved muscle strength, balanced metabolism, ability to maintain weight slightly more easily. A lot of women find that their hair and their skin and their nail grows better. A lot of women who have really difficult urogenital symptoms, so things like vaginal dryness or vulval dryness, despite vaginal estrogen treatment, they're still having issues. And sometimes testosterone is that, the cherry on the icing on the cake that can really help to settle those kind of symptoms. So it does have far-ranging effects. But currently, the research doesn't support a statistically significant improvement in any of the non-libido symptoms. But that doesn't mean to say that women might not experience that. The important thing is that we need to optimize estrogen first and foremost, because when we haven't got enough circulating estrogen, what the body does is it aromatizes testosterone back into estrogen. So you wouldn't get the benefit from being on the testosterone anyway. So we need to make sure estrogen is replete. And then once that's replete and we're happy with that, if there is an indication for trying testosterone, that's when we would initiate it. And often in clinical practice, that's 3, 6, 12 months down the line, once we've actually rationalised and optimised the estrogen progesterone regime.
So it's a two-stage process, really, is what you're saying. Yeah, that's good. That's so interesting. And so it's just really that more research needs to be done so that NICE and the Menopause Society can actually say this is what's helpful. And have you got any studies that are going on? Do you know of anything that's going on to help that research?
I'm not aware of any research that's currently ongoing. I think that there is, a big issue in terms of women being included in research studies, and it's only really been in the last 10 or 15 years that there's been, significant interest in women's health research. Historically, women were often left out of clinical trials because we don't make very stable research subjects because of our hormonal variation, which in itself is a kind of clue to part of the issue. There is limited funding for research across the world, and perhaps this isn't something that is or has been previously a priority. But it's something that a lot of very high profile and powerful people believe needs more research. And so I would anticipate that more research will come, but I don't know when that will happen. And in the meantime, we stick to the guidelines. But, as scientists and researchers, we pay heed to the guidelines and the research. But as clinicians, we treat the patient that's in front of us as well. And we do, what's best for them and counsel them perhaps that the testosterone is not necessarily going to help with their symptoms. But in many cases, trying it is the most useful way of seeing if it's going to be beneficial or not.
That's been just an amazing amount of information on HRT. Thank you so much for that. I am interested though, and in your practice, do you simply prescribe HRT, or do you also look at lifestyle changes that women should be making at this age and stage of life?
Yes, medications and medicines can be really valuable, and they're often the most direct route to, an end point that you're heading towards. But with so many elements of medicine, actually, medications are only part of the solution. So, menstrual health, prenatal, postnatal support, and perimenopause and menopausal care, actually the lifestyle elements are crucial. And I often refer to them in my clinical consultations as pillars. It's really important that you get those pillars or foundations in place so that when we add the medications, there's a good standing for those medications to work as effectively as possible. And it's not rocket science. I think it's things that we all know. But, one of the big twists in Mother Nature's tail is that perimenopause and menopause tends to hit us at a point in our lives when we're at our busiest, we're at our most overstretched. We're often under enormous pressure and strain, both professionally, but in our home lives, with children who are growing up or leaving home, with parents or relatives who are older than us and need us. Relationship issues are really common at this stage of life as well. And it's a natural point where sort of society and culture starts questioning our validity because of our age. And so we can end up in this really quite uncomfortable set of sort of circumstances. And then, nature takes our estrogen and testosterone away, which is really quite unfair when you think about it. And so actually, taking time to pause actually and reflect and use this time of biological change to say, well, what are my core values? Where do I want to go? I've got to this midpoint and I've got the rest of my life to live. How do I want to live it? What do I want it to look like? How can I improve my nutrition? How can I empower my health and well-being by moving more or moving differently? How can I prioritize my mental health as well as my physical health by ensuring I get adequate rest, by being compassionate to myself, by looking after myself as well as all the other people that I look after? Often by this stage of life, we are at the bottom of our priority list and we're not on anyone else's priority list either, So it's really crucial to switch that and to start putting in place important things that I suppose are self-care and that are nourishing to us, in as many ways as possible. So stress management and also sleep. I think it's a really overlooked but really important element of our health and well-being as we're busy, dynamic, driving, excited, aspirational, exploring, moving forward. Often that period of time in the night where we can rest gets shorter because we're busy towards the end of the day, we're busy at the start of the day. But actually, this is a stage of life where we need to be thinking about how do we elongate that time we spend asleep, and also how do we try and create good quality sleep when we are asleep, because that's when all the good stuff is happening. It's when all our cognitive processing is happening. It's also when a lot of metabolic processes are happening. So if you don't get good sleep, you're going to gain weight, you're going to be metabolically less well, which is also going to make your perimenopausal and menopausal symptoms worse and increase your risk of things like type 2 diabetes, obesity, cardiovascular disease, etc. So it's a really important element of that foundation of those pillars of good health.
I think it is really interesting to look at all the different aspects of one's life and see where perhaps you can be kinder to yourself, where you can make more time, where you can think about your long-term health and wellness. And I think you've picked up on all of them. It's nutrition, it's moving more, looking after our joints, looking after our bones a bit more. We talk a lot about lifting weights as well and doing some weight-bearing exercises at this age, again, for bone health. I've got so much more I want to talk to you about, but we're running out of time. Can you tell us a little more about where we can find you online if somebody wants to follow up with other questions?
Yeah, so probably the easiest way to find me, if you're on Instagram, is to go and find me. I'm at the Menopause Medic on Instagram. I'm also at the Menopause Medic on TikTok. although I'm not very good at getting on TikTok. I think I've got a page on Facebook as well, but I'll be absolutely honest, I don't really go onto Facebook very often. As you know, in terms of boundary setting and knowing where my strengths and weaknesses are, I can't do everything all the time. So I tend to focus on Instagram. So if you want to find me there. Or you can go to the website, which is www.themenopausemedic.com. And there is contact pages and things that you can just send me an email directly and get in touch that way. And that's probably the most straightforward way of doing things.
I find some of your short videos really helpful on Instagram on the Menopause Medic, so I would recommend them definitely. And then people perhaps that need more personalised information to come to you directly on the website. That's been an absolute joy and so informative. We've covered a lot of ground, and I think people are going to come away feeling much more enabled to speak to their GP themselves and hopefully empowered to ask for what they need with HRT and recognise the benefits and the risks. Thank you so much for joining us. It's been really, really great.
You're welcome. Thanks for having me.